I'm so excited to see all of you here. My name is Michael Redliner. I am an emergency and EMS physician. I serve as the NAEMSP representative to the National EMS Quality Alliance, which is one of the primary sponsors and partners in this this national quality improvement project to reduce the use of lights and sirens. And so we are incredibly excited to participate in this quality improvement project in this breakthrough series collaborative that Mike Tegman and our faculty are leading. You know, we think that this is actually one of the primary reasons, like, you know, doing a national quality improvement project to work on a specific safety, the implementation of a safety project. I think this is like a highlight of our work at the National EMS Quality Alliance. So we're extremely excited to be involved with it. And, you know, I think one of the things that we've always set out to do is really try to improve this, you know, the reduction of lights and sirens across the country, not just limited to the organizations that are actually, you know, are participating within this quality improvement project. Again, I think, you know, we would love to open it up to everyone. I think we're limited by our specific resources related to, you know, what the software can handle, the number of mentors that we have on board. And so we're really excited to have this day today where we're talking through some of our learnings about what's been going on in this quality improvement project. So I just am really thankful that you all are here. I'm excited to have Jason Gilliam here, who we've brought on as a project manager on this project, and I know he's jumped right in with 2 feet, and he's running along with the project. So again, I'll turn it over to you, Mr. Tegman, for the next steps. But just excited to be here with all of you.
Thank you very much, Michael. Jason, you want to jump in and introduce yourself? Say hi.
So my name's Jason Gilliam. I'm very happy to have been brought on about 2 months ago, and I'm learning a lot. I think the project has, we've run through about 70 cycles so far with different agencies testing change, and it's been a lot of information. It's been really interesting to see what everybody has tried and then the learnings that have come back from it. So I'm appreciating being part of a much larger group.
And what did you do before this?
Before this, I was a paramedic with Austin Travis County EMS. I was a medical officer there, so I did quality assurance for them. I spent a little over 23 years with Austin, and prior to that, I worked for a small fire department. But this was a great way for me to transition out of a role where I had to exert myself in Texas heat all the time. So
sounds good. Sounds good. Sheree, do you want to say hello real quick?
Sure. Hi, everyone. I'm Sheree Murphy. I'm the executive director for NEMSQA, and like Michael said, just excited to be part of this project with all of the other partners improving EMS care.
That sounds great. And I'm Mike Tegman. I'm the facilitator for this this adventure. Hopefully we'll get my PowerPoints up here and working. Are you able to see? Am I in the correct view to show at this point? Yes, this is good. So I'm going to walk you through some of the lessons learned so far. I want to give you a quick overview for those of you. I know some of you are familiar with this, Mike. It's good to see you joining us. It was I hope the rest of your conference went well yesterday. Thank you for inviting us to share our thoughts during that. That was great. So this project, number of kind of little bits of background. We'll get to the learnings pretty quickly. So hopefully most of you have had a look at the EMS Agenda 2050. If you haven't, highly encourage you to do it. It's got basically 6 pillars of the future of emergency medicine in the United States. One of which is to be inherently safe and effective. So this project is totally aligned with and dialed into that part of the agenda for the future. And the idea for this project really came from a recognition that NEMSQA, who is the host and lead agency for this organization, has crafted some really solid measures. There are more measures coming. Yes, I saw a question, Andrew. Yes, we'll definitely make the slides available to anybody who wants them afterwards. I'll give you my email at the end, and happy to send the actual deck to anybody who wants them. But NEMSQA, for the first time, at least in my career, which is now in its 46th year, has put together a set of performance measures that are relatively uncontroversial. Most associations and organizations in the EMS world support these and agree to these. The National Association of EMS Physicians has been running a quality and safety course. Michael Redlener and Scott Bourne have been the founding leads of that, and it's been running for, I think are we in our 6th year at this point in time, I think. So we've now got hundreds of people across the country who are formally trained in improvement science. And the Institute for Healthcare Improvement, which is kind of the epicenter of most of our healthcare related improvement science in the world, have created a system that they call the Breakthrough Series, which provides a mechanism for large scale spread and change of improvement ideas. So combining these three together really sets us up to be able to do something that's really never been done in the world of emergency medical services before, which is to try to improve some aspect of our performance at scale, on a large scale across the country, and hopefully spread this so that it impacts all EMS systems. So our vision in doing this is that we wanted to put together a national collaborative that could do this kind of work. And we chose decreasing the use of lights and sirens because when you look at the NEMSQA measures, it's probably the one with the most variation across the country. There are EMS systems in America that there's one I know of that transports 87% of its patients, red light and siren, to the hospital. And this is a big EMS system. This is not a small one. This is a large EMS system. And there's another EMS system I know of in the country that hasn't transported a patient using lights and sirens in 15 years. And there's the whole spread in between those two. So there's a large variation, and there's a pretty big gap between where we are performance-wise and where we could be. So our second part of our vision is to decrease the use of lights and siren. We wanted to stick with the people-centered vision of EMS Agenda 2050 and make sure we were centering this on the patients we care for, the providers that are providing the care, and the communities that we serve, to nurture a culture of safety and quality improvement across the country, and really build an infrastructure for future projects. Our hope is that by using this framework and this collaborative, that we would be able to engage in projects around improving cardiac arrest resuscitation, improving the outcomes and care for STEMI patients, stroke patients, sepsis patients, number of other topics, and hopefully save some lives, decrease some suffering in the process. So the framework that we're using, I see my friend Hezadine has joined us. I have to give him a shout out here. This framework put together by the Institute for Healthcare Improvement is designed to kind of start by selecting an area where improvements have been made. In this case, we have several EMS systems that have dramatically reduced their use of lights and siren for both response and transport. So we brought them together as topic experts, along with experts in improvement science and experts in dispatch and clinical medicine. We've got a pretty remarkable faculty, folks that include Dr. Redliner, Dr. Jeff Jarvis, Dr. Doug Kupas, Dr. Jeff Clausen, the folks from Niagara EMS who've made dramatic improvements here, the folks from EMSA in Tulsa and Oklahoma City, Dr. Jeff Bidlow and their team, all came together and basically designed a change package for systems to go out and test. So this is a list of specific actions you can do, almost like a recipe for how to make meaningful improvements in your local EMS system. Then we recruited systems from across the country. As Dr. Redliner shared at the beginning, we had a limit as to the number of seats we had, a number of organizations that could participate based on basically the bandwidth of the software and the amount of mentors that we had available. So we selected 50 of the first 106, I think it was, that applied, and we basically took first come, first serve. And then we brought them all together for an initial learning session where we taught them the basics of improvement science and shared with them the change package. So the basics of improvement science. I'm not going to dwell on this a lot, but we use the model for improvement. This was created by the Associates in Performance Improvement in Austin, Texas, and these folks were essentially the road crew for Dr. Edward Deming, who is really truly the father of improvement science in the U.S. and across the world. And the first part of the model asked the question, what are we trying to accomplish? And this is where you come up with an aim. And an aim basically describes what you're trying to improve, how much, and by when. So for this project, our actual macro aim is to reduce emergency vehicle involved crashes, including the deaths and injuries associated with those associated with 911 response and transport. My dog is very excited about this particular thing. You'll hear her in the background. And the project aim, since reducing crashes, most systems don't have enough of a concentration of crashes, thank God, to be able to have a meaningful measure to improve on. So kind of a process measure, which is the focus and aim of this project, is to reduce the use of licensed sirens for 911 responses so that 70% or more of responses do not use licensed siren, and 95% or more of transports are done without the use of licensed siren. And some of you are likely wondering a little bit about, why do we say things this way? And with the NEMSQA measures, all the NEMSQA measures are designed so that as they go up, that's improvement. So we want to improve the percentage of patients that are transported without licensed siren, which is the way we monitor and track this particular one. So our measures for this, our process measures are the NEMSQA Safety 01, which is the percentage of patients transported without the use of, or responded to without the use of licensed siren, and NEMSQA Safety 02, the percentage transported without the use of licensed siren. And we've also got the number of crashes for all the involved systems that we're tracking as well. And then the next part of the model for improvement are the change ideas or change theories. So this is the change packages, and we've got a number of change ideas that our systems are working on testing. As Jason said, we've tested over 70 of these in the various systems that are involved. So one of the change ideas is to add the use of licensed siren in, just like you would add the use of a new medication in to your clinical protocols. So if you were going to add droperidol to the list of medications you were going to have for patients, you wouldn't just say, here's droperidol, use it whenever the heck you want, or don't use it if you don't want. You would say, here are the patients that it's indicated for, here are the contraindications, here are the side effects, here are the things to consider in its administration. Here is the dose and those kinds of things. Since licensed siren is a clinical intervention, it is designed to produce a result. We're encouraging people to add it to their clinical protocols with that thought in mind. Also, the dispatch protocols and our dispatch systems, including medical priority dispatch and other call taking and classification systems. They give us some information about whether or not licensed sirens are appropriate, but they don't prescribe them. So the change idea and suggestion is for individual systems to give dispatch protocols to guide the use of licensed sirens. So there are a number of other test ideas that our participants have worked on for the last 6 months. And then the next part is to collaborate on a second a learning session where we collaborate on the lessons learned. That was held 2 weeks ago. And now our groups are in the second round of testing and shared learning. The way to think about improvement is that you do small tests of change using plan, do, study, act cycles, where you plan a test, go out and do it, study the results, where you basically compare the results to what you predicted would happen in the plan, and then you act by deciding that this is something that you're going to adopt as a change and go forward and do a larger change with it, adapt it, maybe alter it a little bit, or abandon it as a completely bad idea. So the overall project timeline, we actually started before January of 2022 putting it together, but we are right here on track and on time with our performance so far. And then the next steps from here will include finalizing and implementing and publishing a final change package. So with that, I want to jump into some of the change ideas and some of the lessons that have been learned. Before I do that, any things I missed? Any questions, comments, quips, quotes about where we are so far in any of this?
No, you're doing a great job, my friend.
Thank you, Azzedine. I appreciate you more than you know. All right, let's talk a little bit about some of the things we've learned. When you're doing PDSA cycles, there's really 2 types of PDSA cycles. There's a PDSA cycle to gather knowledge and gather information, and then there's a PDSA cycle to implement a change. So in the knowledge gathering perspective, a number of our systems went out to make assessments in their community around what the community's reaction would be to decreasing the use of lights and sirens. And probably the biggest example of the learning from this is I talked with one EMS medical director in the Midwest, who actually a few years before our project started, 2017, said, hey, we respond to lights and sirens, using lights and sirens way too much. It's unsafe, and we're gonna make a change. So he went through their dispatch determinants and said, we're sending lights and sirens on all these. We're only going to send lights and sirens on these ones that really matter from here on. And he just implemented the protocol. And the medics got all kinds of lit up because they weren't necessarily consulted on the change. And they started social media groups talking about how their system was going to, leave dead babies in the gutter and all kinds of horrible things. The news picked up on it. It kind of lit up. Everybody started kind of complaining with a big kerfluffle in the community. This medical director works for a hospital full-time, and the hospital provides the medical direction. So the CEO of the hospital brought the medical director into his office and said, what the heck is going on? And the medical director said, hang on here. Here's the science. Here's the evidence behind this. This is the right thing for us to do. And the CEO of the hospital said, who is also a physician, said, you've made a really good case. I agree with you, but your implementation needs some work. I've got the mayor calling me nonstop. You need to call and talk to the mayor. So he, medical director calls the mayor, and the mayor says, I have got constituents up in arms like nobody's business. And the medical director says, well, here's the science behind it. Here's why we're doing it. And the mayor says, I agree with you. I've got your back on this, but we have some PR stuff to manage. So we're going to hold a press conference tomorrow afternoon and invite people, and we're going to explain to the community what we're doing and why. And the news stations before the press conference went to the busy downtown areas in this area with microphones and cameras, and they went up to pedestrians in the downtown area and stuck microphones in their faces and said, if you've been shot or you're having a heart attack, is it okay for the paramedics to kind of lollygag and just take as much time as they want to wander over to take care of you? Or do you want them to put on their red lights and siren and get to you quickly? And of course, that answer was preordained in the question. So people were pretty lit up for the press conference. They managed to get through the whole thing okay and settled out, and they have stayed with their decreased use of lights and siren, but there was a lot of pain and trauma in the process. By contrast, one of our system participants, Santa Cruz, their system, between the fire department and the private ambulance provider, American Medical Response, Brad Kramer, and colleagues out there, they went out to do public listening sessions and float this idea. So they went to neighborhood groups, they went to senior citizens groups. They actually got invited to a group that manages transportation for disabled people in their community, and they were invited to come talk, and went and shared this idea. And one of the participants, who's visually impaired, is blind and cannot see, said, so if I'm having a heart attack or I get shot or I have a stroke, you're still going to come to me with lights and siren on, right? You're going to come fast. And it was like, oh, yes. We're not talking about wiping out lights and sirens completely. And she said, and you're only going to quit using lights and siren for these ones that really don't need it. And it was like, that's the plan. And she said, well, let me tell you what life is like as a visually impaired person in this town. She said, my apartment is downtown because I need to be able to walk to the grocery store and to the drugstore and to my doctor's offices and those kinds of things, since clearly I cannot drive. And she said, when I'm walking to cross the street, the crosswalks, they have the auditory signals that tell me when it's safe to go across the street. And she said, at least once a week, when I am walking across the street, I hear a siren coming toward me. And she said, I don't know. Am I supposed to go forward? Am I supposed to go back? Am I supposed to stand still? Am I going to get run over by a police car or an ambulance or a fire truck or whatever? Boy, if you would cut down the number of times I have to do that, I would bake you a cake. It'd be wonderful. And so through the community conversations, and they actually met with some homeless coalition folks, a number of different folks in the community. They didn't find anybody who said, I really want you to be using lights and siren. Pretty much everybody was okay with it, but the process of socializing that idea is really powerful and really helpful. And one of the things that some frontline participants have brought up in various systems is, but wait a minute, aren't we opening ourselves up to liability if we stop running lights and sirens? So we have asked the EMS lawyers that are part of our project and scoured the legal literature, and it may happen at some point in time, but it hasn't happened yet, where there has been a lawsuit because somebody did not respond using lights and siren. Now, there are a number of lawsuits that involve crashes that were caused by the use of lights and sirens, so it's probably a bigger liability to run hot than it is to run cold. Jason, Michael, Mike, anybody else from the team? Any other learnings from the assessing community expectations that anybody can come up with?
I really liked Brad Kramer's. He had a really wonderful piece of advice that I'll always remember. I think it's very spot on. He said, nothing about the patient without the patient. So if you're going to make a change and it involves a patient, make sure you include them in the decision.
Absolutely. And that's a Don Berwick quote from the Institute for Healthcare Improvement, which is powerful. Don't do anything for me without me in it. And Don would extend that to the employees as well, which is the kind of the next change idea and assessment. And we've had a number of systems really socialize this. Let's see, I think I just switched to the assess employee expectation slide. Are you seeing that one now? Okay, yeah, I hesitate to ask a quick question there. In assessing employee expectations, probably one of the best systems that has dived into this is Plum EMS, one of our participants, and they're a small organization. They've got a handful of, I think it's like 36 employees on their team, and they really sat down and said, what are your thoughts? What are your concerns? What are your expectations? And they got some of that feedback. But what if the call comes in as a sprained ankle, and it really was a sprained ankle because they were running away from a shooting, and they've got 3 gunshot wounds in their chest and they're bleeding out, and I go non-emergency to them, and they bled out because I went non-emergency or whatever. Those, a lot of those what if conversations come up, and those of you who've been in EMS for a while, you can probably all think of a case where you were dispatched on something that sounded innocuous, that turned out to be a really critical, life-threatening medical emergency. They do happen occasionally, not very often in most systems these days. But that was one of the concerns they brought up, and the participants in our collaborative here have been kind of responding to that by saying, what if you get involved in a crash on the way to a non-emergency situation? That's something that really doesn't need time-dependent medical intervention. And I thought back to the first ambulance crash I was involved in, and yes, I was driving the ambulance running hot in the city and county of Denver, where I was a paramedic, and coming through an intersection. It was an intersection where there was 6 lanes each direction, on two big roads, 6 lanes each direction for each road. And a large city bus had pulled partway into the intersection. I was coming through the intersection, looked up to the right, and saw all the traffic stopped coming from the right-hand side. Looked to the left and saw that people were stopped in the inside lane. Looked back to the right to make sure the traffic had stayed stopped. And as I passed the front of the bus, I got tagged by a Dodge Power Wagon doing 45 miles an hour. Totaled his Dodge Power Wagon, totaled my ambulance, which was a brand new ambulance that had 1,600 miles on it. My boss was really happy about that. Fortunately, nobody was injured in the process. Another ambulance was dispatched to the call I was responding to, which actually did turn out to be a sprained ankle. So we, created all of this havoc, destroyed a lot of property. Fortunately, didn't injure anybody for a situation that was really not going to benefit from the 1 to maybe 3.5 minutes that are saved by the vast majority of licensed siren responses. So in the conversations with employees at Plum EMS, what they have done is they first off, they've been incredibly clear they're non-punitive about anything that they do, and they have decided that they're going to review and provide feedback on every licensed siren response and transport, and say was this the right thing to do really or not, and does it make sense, and not in a punitive way at all. And one of the things they've got their hospital on board with is providing a hospital outcome. And it's basically, if you're transporting hot, was there a time dependent clinical intervention that was performed in the emergency department within the first 10 minutes of arrival at the hospital, giving a really big cushion. And there's not a lot of science about this. The one study I've been able to find was a trauma center that looked at patients that were transported hot to a trauma center. And they listed potentially life-saving interventions, including intubation, chest tubes, and potentially the cracking of the chest, although that's not done very often anymore, to intervene. And of patients that were run hot back to this particular trauma center, it was like I think it was like 12% of them had some intervention done, and 75% of those interventions were intubation, which potentially could have been done in the field before the arrival in the hospital. So in the assessment of employee perspectives, a number of 30, 40-year EMTs and paramedics have said, it would really have decreased the stress in my career if I didn't turn on lights and sirens so much. And, we've been concerned that, it's like, it won't be fun anymore to work in EMS if you don't get to use the lights and sirens so much. And that really hasn't been the feedback we've gotten from the employee conversations that have happened so far. Any other thoughts on this topic from anybody? All right, let's move on to clinical protocols. And the change idea has been to bake lights and siren into clinical protocols the same way you do medications or needle decompression or cricothyrotomy or any other intervention that we use is in the care of patients. And the one thought that's been interesting and interesting learning over this is, some places went to be really prescriptive for the inclusion of lights and siren in their protocol and pretty strict around it. And they have other people have pushed back, including Dr. Kupas, actually, who is really one of the forefathers of this whole concept and topic. And saying that you need to have some provider discretion because, there are circumstances about, the patient situation, the traffic, all of those kinds of things that it's hard to include in the clinical protocol. So for example, Dr. Redliner works at Mount Sinai Hospital in New York City. And I've ridden along with FD, or it was actually Department of Health and Human Services before EMS went to FDNY. But there are, with traffic being locked up in New York City sometimes, it can take you an hour to go 3 blocks in a vehicle. So using lights and sirens to part the Red Sea a little bit, to move through stop traffic presents a very different risk profile than blowing an intersection at 45 miles an hour. So, having some discretion where frontline providers are educated about the clinical benefits of the use of lights and siren and being able to think about the context in which they're using it probably makes really good sense. Any thoughts from anybody else on the use of clinical protocols? Most of the clinical protocols are, if you've got an airway that you cannot secure, if you've got uncontrolled hemorrhage that you're not able to control, those kinds of things, they make sense for the extra 2 or 3 minutes you might save with transport. There is a little bit of a debate about, when it comes to a STEMI or a stroke or a cardiac arrest, for transport in particular, is the 2 or 3 minutes saved in a lights and siren transport worth the extra stress on the patient's myocardium if they're having a STEMI? And is it better to focus on saving time in the hospital as far as getting people to the cath lab quicker, getting people to a CAT scan quicker, being able to clear off the cath table for elective procedures faster? those kinds of things when you're looking at the, the time to reperfusion for those occlusive or hemorrhagic situations. And I don't know that we've got a definitive answer, Dr. Redlener, Jason, anybody, if you want to weigh in on this, I'd love to hear your thoughts.
I think that there could be some complexity to this just in terms of aligning operational and clinical guidelines and guidance. And I think it's really important to have those discussions in earnest with the people who need to make those decisions. I do believe empowering the frontline provider to have some discretion within a certain framework. I think that it's important to make sure that the guidance in the system is designed to support people making smart decisions. So I think that every system is going to be a little bit different, but conceptually I think I think there is a belief among some leaders who do this work all the time that lights and sirens is a medical decision, right, with a safety profile. And so I think that we should think about it in that way as well.
I think there was also some concern that some providers had that if they chose to not take a patient code 3 to the hospital post arrest or something, that they would get into hot water because the patients, we've just got pulses back and now we're going to take him slow to the hospital. Somebody's going to look at me and think I'm doing something wrong. And while that's probably very appropriate because we don't want to lose an airway and we want to maintain safety, and there's a lot of reasons why going slower or not lights and sirens makes a lot of sense. Having a medical directive or some sort of a prescriptive procedure helped the provider feel like they had a little bit of cover.
And one of you bring up a good point, and that part of socializing this idea definitely needs to be done with your hospitals. There are hospitals that sometimes choose their level of activation based on whether or not a crew's coming in hot. And you'll hear in the emergency department, hey, we got somebody coming in hot with a trauma, a STEMI, a stroke, or whatever it happens to be. And decoupling the transport mode from what activation happens in the hospital is important, I think. Dave Bryson, thank you for adding the link to the chat. Do you want to just real quick unmute and let people know what it is you've shared?
Certainly, and I think Max Severide might be on the call and could probably more appropriately, but we're in version 3 now. The National Association of State EMS Officials launched version 3 of the model clinical guidelines, easier said than done. And if you go to their site and look at those, there are a number of places where throughout those clinical guidelines, they're kind of a tool to be used by states, regional, local systems to kind of assist with the protocol development. And under patient safety considerations, under a number of the clinical issues are things like right up front say routine use of lights and sirens is not warranted. So cases where pediatric COOP patients are actually responsive to the treatments still need to get a definitive care. So they've taken that extra step, and I know Dr. Kupis and probably a number of folks that happen to be on this call were involved either as subject matter experts or helping out with that. So it's refreshing and good to see that statements like that are made for certain patient presentations. I think that's a step in the right direction and kind of supports what you were just saying, Mike. That's all I wanted to add, and that's why I put
Perfect.
Yeah, thank you, Dave. This is Max Severide. I don't really have much additional to add. He stated that very well, as he mentioned that the patient safety considerations about routine use of lights and sirens not being warranted is definitely pervasive throughout a number of the different model clinical guidelines in the SEMSO's most recent version. I would mention that, one of the things that is also might be considered is when entities are considering doing this more, maybe even partnering with their state highway safety partners who maybe in the past haven't really been part of this discussion, but honestly might be very interested in being part of this discussion because they can certainly help take those messages to the public. It's interesting to see that there's these contentious public outreach needs, to make sure that the public understands the process. But anyway, thank you for the presentation.
And thank you both for your contributions. I see Brian has got a couple of questions in the chat. Brian, are you up for unmuting and let's have this discussion so everybody can benefit from it.
So kind of was just tagged to some of the conversation points throughout that were raised. Looking to kind of get some clarification on the mindset of the provider. We're entrusting the paramedic providers to make the decision to intubate or not in settings of respiratory failure or whatever the clinical condition may be. Why are we then prescribing so much so the decision whether or not to use red lights and sirens instead of treating it like any other intervention and leaving that decision-making process to that frontline provider? And it was kind of touched on and empowering them to do so, but at what point should that not become exclusively their decision based on their education and understanding of the risk and benefit, like any other intervention?
So I'll tackle this first, and then I'll invite other people to jump in. So I think there's a spectrum, right? And we don't allow providers to intubate sprained ankles, and they don't they don't use active airway management unless it's indicated, right? So and the same thing's true with analgesic pain medication and conscious sedation for procedures and those kinds of things. There are guidelines and there are indications and contraindications for when to use it. So and the way I tend to think of it is we provide no guidelines, you get great variation. There are, in systems where there are no guidelines, you will find some people who they just transport everything hot because they have a theory that they need to get back in service faster or something like that. And other people are like, I never go hot to the hospital. I'm a good medic. I can take care of my patients. I just don't need to. And so having the practice of medicine be based on good practice of medicine by providing people with some guidelines and the protocols is what we're suggesting. We're not trying to take away all of the autonomy and power for folks. We're trying to give them a framework and guidance to work with. And I'd love to hear, I see Mike McAvoy's jumping in, Jason, Michael, anybody, what do you think?
I think that's exactly right. When I see protocol, I see guideline. And to me, it's more instructive and less restrictive. But I think that different services may see that term differently.
Yeah, and that was the gist of my comment. This is Mike McAvoy. Is, I think when you're first starting with this and you're running nearly everything with lights and sirens, I don't know that it's smart to give people the option of bucking some change. But I think when you start getting to the point where you're running very few calls with lights and sirens, people seem to then grasp what you're trying to do. And I think giving providers the discretion, I mentioned this on an educational program yesterday, that when you look at Nova Scotia, where they're down to maybe 5% of their transports being run with lights and sirens, or even less, and maybe 5% of their responses, 10% of their responses, the way they got there ultimately was to give the provider discretion to people to be able to make those decisions. And I don't think they would have gotten to where they are had they not taken that step.
That's a good point. And our Plum EMS group, which has made dramatic improvements in their both response and transport for lights and sirens. They actually haven't baked it into their protocols yet. But they're a small group and they've had really detailed one-on-one conversation and 100% review and feedback on everything to really improve that knowledge base and decision making for folks. So everything is viewed and looked at. Good.
Yeah, Mike,
Michael?
if I may.
Yeah.
If I may, good job and good discussion. Just want to say good afternoon, everyone. And I like the initiative that has been undertaken and the research that has been done. And I think thinking ahead, we just got to probably start thinking, and I'm sure other thought leaders out there already down that path already, in terms of fire-based EMS systems and certain expectations, whether it's, accreditation numbers and what's expected at the 90th percentile, that kind of thing, and the implications that this will set, or the framework that this will set in terms of guiding those decisions moving forward and addressing some of those, I don't want to say unrealistic benchmarks, but those benchmarks that certainly should be looked at in terms of service delivery. And then on the other side of things, also looking at the cross section of the implications for equity and service delivery as it relates to the no lights, or should I say the Lights and Sirens initiative.
Yep.
So I think we're on a good path, and I'm looking forward to how this actually will transition or transfer into other domains, if you may, in terms of measurements and establishing frameworks across the country.
Absolutely. And you bring up a good point, and actually Ben Purdy just made a comment in the chat as well. And we specifically did not tackle fire response use of lights and sirens. We did not tackle law enforcement use of lights and sirens. We're staying in our lane, but there's obviously some bleed over, and there are many places where all of EMS is provided by the fire service. And we've got a number of fire services who've made some pretty dramatic changes in their lights and siren responses as part of this collaborative, which I think is wonderful. And Ben, to your point, the issue around, what if it's cardiac arrest on a lift assist, and lift assists are sometimes they are cardiac arrest. That is true. So the way I would approach that as you're getting ready to work it within your system is get real data from your system and take a look at your responses by call type for the last year, and take a look and see what percentage of your lift assists resulted in transports, and of those, what percentage of those were cardiac arrests. And if you've got 20% of your lift assists are cardiac arrests, there's some call taking education that I would tackle before I switch to a non-light and siren response for lift assists in my community. But if you looked at it and you had 400 lift assists in the last year, and one of those was a cardiac arrest but was clearly a DOA and not resuscitatable, then I think you're in a better position to make the argument. And the other part of it is getting clear on what the risks are, and looking at crashes across the country that involve fire rigs. I mean, if you Google crashes involving ambulances or fire rigs at any day of the week, you will always come up with stuff that's fresh that day. Good stuff to think about. Any other thoughts here? Let's see here. I got a couple of other things.
Mike, I would like to make just a quick comment. We think about these things not only in the pre-hospital setting, but in the hospital. And so even when you're looking across a group of, whatever type of providers, whether it's EMS and, paramedics or physicians or other providers, there is essentially a bell curve of like how conservative some people are and how aggressive other people are. And you'll see, for example, like in a syncope admission, that some providers are much more aggressive with admission versus sending the patient home after appropriate evaluation. And if you look at the evidence, really the number of syncope admissions should be very low. And some people practice outside of that kind of standard guidance. So really, I think what we're trying to set here is the guidance in general, the more, again, an evidence-based practice guideline. And what we're trying to do is reorient the way that the community is thinking about it, changing kind of the norm and the standard. And, I think probably like Mike McAvoy was saying, it's like there's a period of time where you just have to move in that direction. And then around the edges, when you're with an individual patient, there's going to be some differences on that individual level that, yeah, I do think requires some flexibility. And so I think, again, I think this is not a question of, whether or not paramedic can make a good decision or not. This is about really shifting the way that we think about this. So, I think that there's two ways, I think both are real ideas and real problems, but I think they exist side by side, but you really have to make a move to change the system, I think is important.
Sounds good. So the other hot topic in this kind of similar domain is dispatch protocols. And we have a number of places that have done some innovative, really improvement science and data-driven changes to their dispatch protocols. Probably the folks at EMSA with Dr. Goodlow and his team there have made some of the best ones so far, and they have published them on our shared platform. There are the folks in Niagara have done some really fabulous work on this. The state of Pennsylvania, under Dr. Kupas's guidance, have done some great work around this. So we've been able to pull that out, and you can get under 50% responses with lights and sirens without too much difficulty and too much risk using the frameworks that they have shared. We've talked a little bit today about the education of providers, and I think that is an important part of it. I also think that including this as core education in your base EMT and paramedic program is important, and kind of take away the myths and the excitements of lights and siren is powerful. And then the one other learning that I want to mention here real quick is that some places have coupled the use of lights and sirens with how they code things on their Medicare and Medicaid reimbursement forms, and that turning off the lights and sirens may have financial implications for systems that do that. So there's nothing in the Medicare reimbursement regulations that couples the use of lights and siren. They do use the phrase emergency and non-emergency. So uncoupling those is key to that. And so what I want to do here is turn it over to Jason real quick. Jason has been hosting some collaborative works and working one-on-one with our participants. And I just wanted to give you a couple of minutes to share your approach and what you've been doing. You've got 5 minutes.
So we've had a really nice opportunity to learn from all of our different teams. And recently we've started having discussion groups where we bring the teams back together based on what driver they're working on. So we had a group that met last week or earlier this week to discuss dispatch protocols and changes that are made. And that way we can also delve into the difficulties that different agencies are experiencing with making changes in dispatch protocols and share out the learnings. That way each team is able to discuss and make changes that have been made by other places, so they don't have to relearn things. We're also going to have a upcoming meeting with another one with different teams about where we're going to work on community expectations and how to deal with community expectations, because you can't really, like Mike had talked about earlier on, you don't want to make a change until your community is aware of it, and you want to make sure everyone's prepared and ready for it. So that's a bigger challenge for a lot of agencies, and how to share out what you're going to do and get buy-in from your community and make sure that your community feels comfortable with it before you make it. And then we'll have another one involving employees and paramedics who are concerned about making changes because they're worried about the lift assist. It's going to be a cardiac arrest. And I think, finding commonalities, like in a break room, most paramedics will complain. They always complain, right? As a paramedic, I'm a big complainer. So we can sit in a break room and we'll complain about the call that happened. Either we didn't have fire on it when we needed it, or it wasn't really an emergency and everyone's upset that we went code 3 to the guy who had chapped lips. And if you can identify commonalities that people can all agree on that didn't meet certain that really didn't need a code 3 response, then you can get buy-in from your staff a lot easier. So having groups that can share out their learnings, I think has been it helpful. We're also able to meet with individuals who have questions so that we can start helping them build out PDSA cycles to gain improvements. Sorry, Mike.
No, it's good. You're good.
So I think dealing one-on-one with people is very helpful. It has been good for the individual teams we've been working with, but also getting those teams together. I rarely have an answer for anyone. I shouldn't say that on a big webinar, right? But I don't usually have answers. But what I found is that most people have the answers inside their teams. And if you ask questions and people start explaining things, usually the answer comes to the surface and it becomes more apparent to them. And I think that having discussions is always a way for people to clarify their own minds. So that's what we're seeking to do.
That sounds great. That sounds great. Let's see, we got Charles, you were asking about has this been shared with the CAS, the standardizing committees, and the answer is not specifically yet. I think our intention and our plan is once we have gone through the next learning phase and we are looking to publish the results of this along with recommendations for all EMS systems in the country, that we'll be sharing this with all of those committees, organizations, and all those kinds of things. All the parent associations have been involved in the planning and included upfront in all of this stuff, but we don't want to give them recommendations before we're done testing. We don't want to go to make the mistake of jumping to implementation when we haven't finished our PDSA cycles.
This type of quality improvement project where we're really kind of gathering knowledge from actually making changes throughout the country in many different contexts. I think that there's just so many common themes that are arising that we'll be able to share. And what I really just kind of love this idea as a project of a national quality improvement project. So as we kind of wrap up we'll never totally wrap up the learning, but as we complete this kind of project cycle, we'll be looking to do other quality improvement projects. And I anticipate that, in my mind, this is really where the money is, right? Where maybe not the actual money, but where the importance lies, where we're taking an evidence-based measure and we're building the implementation strategies and opening it to the EMS community. So I hope that this is just the tip of the iceberg, this is just the beginning of the work that we're doing around improving.
And I hope you have a very safe and crash-free summer for all of you. Take care, everybody.